Hello and welcome. I am Dr. Mark Ballo. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for today's educational activity entitled A Multidisciplinary Approach to the Diagnosis and Optimal Management of Primary Immune Deficiency, the latest evidence and best practices. I do want to let everyone know that you will be seeing PI, PID, and PIDD, which all stand for primary immune deficiency. These are all correct, and we will be using them interchangeably throughout today's presentation. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. I also want to make everyone aware of some great resources we have available. I partnered with CME Outfitters to develop 3 patient education tools. The first one is a whiteboard animation describing primary immune deficiency and what to expect during the diagnosis and treatment phases. The second is an FAQ checklist for patients, and the last one is a video providing insights into shared decision-making strategies for patients to improve communication with their clinicians. I want to encourage you to visit www.cmeoutfitters.com/PID to gain access to these very useful tools for yourself and your patients. I hope you find them useful. Again, I am Dr. Mark Ballo. I am professor in the Department of Pediatrics at the University of South Florida, Morsani College of Medicine, Division of Allergy and Immunology at Johns Hopkins All Children's Hospital in St. Petersburg, Florida. Let me now introduce our faculty joining me today. Let me start by welcoming Dr. Niraj Patel. Dr. Patel is Chief of Pediatric Infectious Disease and Immunology, Director of the Charlotte Immunodeficiency Center, and Adjunct Associate Professor at the University of North Carolina at the Levine Children's Hospital, Atrium Health in Charlotte, North Carolina. Welcome.
Glad to be here.
Also, let me introduce Kristen Applin, who is a family nurse practitioner at the Midwest Immunology Clinic in Plymouth, Minnesota. Kristen, welcome.
Thanks for having me.
Thank you for joining us today. Let me jump in with our first learning objective, which is to identify the signs and symptoms of primary immunodeficiency to decrease diagnostic delays. I'm going to start by getting the audience involved. You will see a question on your screen, and I ask you to give us your response here. The question: which of the following primary immune deficiencies are the most common? A, severe combined immunodeficiency. B, humoral or antibody immune deficiency. C, phagocytic abnormalities. D, T-cell immune deficiencies. Or E, complement defects. Please answer now, and I'll be sharing the results with you shortly. Niraj, can you give us a little bit of background on PI and what the prevalence of PI is in the general population? And finally, what are the distribution of these immune deficiencies?
Sure, Mark. So primary immune deficiency, or PI, is a group of genetic disorders, and they involve either absent components of the immune system or dysfunctional components of the immune system, often resulting in recurrent infections. Now, while there's multiple components of the immune system, by far and away the most common immune system defect is typically humoral or B-cell deficiencies. Prevalence of immune deficiencies vary widely. Very common immunodeficiencies like selective IgA deficiency is prevalent in about 1 in 600 persons, CVID in about 1 in 25,000 persons, and then some of the more rare disorders like severe combined immune deficiency, or SCID, 1 in 65,000 persons. And these humoral deficiencies are probably what we see in our practice most often.
Kristen, do you have any further thoughts on the implications of this?
I think clinically, these are the patients that we're all seeing in our practice as the frequent flyers. They're coming in frequently with recurrent infection, and sometimes not just your run-of-the-mill infections, but strange, odder infections. These are the patients that you get a sense that you're seeing too frequently.
So Niraj, on the next slide is a compilation of the data from the International Union of Immunological Societies in their publications on the inborn errors or genetic mutations in primary immune deficiency and autoregulatory abnormalities. Can you comment on this?
Sure, Mark. As you can see from the slide, that the number of known genetic disorders identified has increased tremendously, probably because that primary immune deficiency disease encompasses a broad phenotype, not only recurrent infections, but as you mentioned, autoimmunity, autoinflammatory. And I think for this slide, it really takes to point that the genetic identification of those disorders is very important and can help target therapy for those patients.
So one of the important things is a delay in diagnosis. Perhaps you can comment on this. And on the right panel is the age distribution of PI.
Right, so on the right-hand side of the panel, you'll see really what is probably two different distributions. So the first distribution, or age range 0 to 6 years of age, is one of the common ages to diagnose a PI. And then a second peak, the third or fourth decade of life. On the left-hand side shows the average delay in diagnosis. And while the average delay combined for all decades is roughly 12.4 years, which is a long time from the time that somebody develops symptoms to the time that somebody is diagnosed, you can see that for the last decade, in the 2000s, we've improved a little bit up to about 5.5 years on average delay of diagnosis. So clearly, Mark, we have a long ways to go.
So we're going to weave a patient case throughout our presentation today so we can translate the data to real-world practice. So here is Deborah. She's a 43-year-old woman. She's had asthma since the age of 10. She's been hospitalized several times, most recently about a year ago. She has chronic bronchitis with persistent cough, productive of sputum, particularly in the morning. She's on the appropriate asthma medication. Interestingly, allergy skin testing 7 years ago was negative. She has recurrent sinusitis that's appropriately treated with washes and topical nasal steroids, etc. And her past history includes ITP about 10 years ago. Kristen, what do you think of Deborah's clinical findings as it relates to the possibility of an underlying immune deficiency?
I think the lesson here is that not only has she had frequent infection, but she has a mix of other things kind of throughout. Jeffrey Modell has produced the 10 warning signs of primary immunodeficiency, not only for clinicians, but this is also a public awareness campaign too, so that patients can be tuned in a little bit to some of the warning signs of primary immunodeficiency disease. So for Deborah's case, I don't think it's the frequency alone that puts her at risk for primary immunodeficiency disease. I think it is also the types of infections that she's getting. I think it's really important to stress here that she has an autoimmune factor with her ITP, and cytopenias sometimes are a big warning sign for primary immunodeficiency disease. So I think on the list of risk, Deborah's risk of having some underlying immune deficiency is very high.
Well, let's look at her physical examination, which is shown on this slide. She has inflamed nasal mucosa with some yellow secretions. She has cobblestoning in the posterior pharynx with some, again, secretions. Her chest exam showed scattered bronchi and wheezes. Interestingly, the abdominal exam shows a palpable liver as well as a spleen tip. And she also has some lymph nodes, not only in the neck, but also in the right axillary. We did get some imaging studies on Deborah, and you can see from this slide, which is a sinus CT scan, she has pansinusitis involving all the sinuses and perhaps even an air fluid level on the left side. We also got a regular chest x-ray, and there's some air trapping and some increased markings in the lower lung fields, but certainly consistent with chronic asthma. But this is not enough. So we went further and got a high-resolution chest CT, and this really shows underlying pathology with bronchiectasis and even perhaps some nodules in her lung, which we'll discuss in a few minutes. Let's talk about her humoral immune evaluation. Kristen, can you make some comments?
I always tell my patients that I never see a patient without starting with a CBC. So I don't even know how to interpret data if I don't know, what her 3 lines of cells look like: hemoglobin, white count, platelet count, and more specifically, lymphocytes. Our differential is really important. Starting with quantitative antibody studies is the base, right? What are her IgG levels, specifically her IgG subclasses? What is her IgA and IgM levels? And in most cases, I also look at an IgE level in patients. Then the second phase of the workup would be to take a deeper dive into the antibody itself and look at the quality of her antibody production. So taking a look at vaccine responses. If the patient is fully vaccinated, we should be able to measure vaccine responses at any point. And we start looking at the qualitative antibody assessment in as little as a 1-year-old child who has started their primary series of vaccines. We also do a test called the Hemagglutinin Titer. So Hemagglutinin titers look at a patient's blood type. And especially into the adult years, you should be able to measure an antibody response against opposite blood typing that represents a not vaccine stimulated response. This is the patient's own immune system learning antibody response against opposite blood type. In the vaccine specific assessment, we will oftentimes vaccinate a patient and look at their post-vaccine response at the 4 to 6 week post-vaccination time frame to see how they did initially, turning that exposure into antibody protection. So that's the second stage of the immune assessment. The common vaccines that we will use, Tdap, tetanus and diphtheria norms are well documented. And so immediately post-vaccination, at the 4 to 6 week mark, we should be able to measure a response to both diphtheria and tetanus post-vaccine. Pneumococcal vaccination with the Pneumovax is also an important trigger as a pure carbohydrate stimulant to an antibody response. And we can measure 23 different serotypes of pneumococcus, so that gives us a lot of data. Depending on the time of the year and the age of the patient, we can do influenza titers. If they're 4 to 6 weeks post-influenza vaccine for the season, we can oftentimes look at that titer. And then Haemophilus influenza B is a conjugated vaccine and is in a part of the primary series of vaccinations. Interpretation on Haemophilus type B response in adults is not as well defined as tetanus, diphtheria, and pneumococcus.
Niraj, what are the next steps in immunological evaluation? When should a patient be referred to an immunology specialist?
Sure. So, Mark, really the next phase you want to look at are lymphocytes. And lymphocytes are cells that are important in response to infections and immunity. These lymphocytes, including T, B, and NK cells, can really help immunologists and practitioners understand particular types of defects. So for things like Bruton's X-linked A gamma globulinemia where no B cells are present, or certain T cell disorders where T cells are low. More specialized testing, including B cell panels, T cell panels, and how lymphocytes function, like lymphocyte proliferative responses are really important. I would say to Chris's point that when there are abnormalities in immune system testing, such as humoral deficiencies, then a referral to an immunologist should be considered. And also, if the immune testing that a practitioner does is even normal, but there's a strong suspicion for an immune deficiency, that would be another appropriate time to refer to an immunologist.
So let's go back to Deborah. Chris, can you highlight some of the labs that we obtained in Deborah?
Absolutely. We put the CMP, the Comprehensive Metabolic Panel, on the top. Important to note, out of that metabolic panel, she had normal serum protein levels. And then down the list, her blood counts look great. She has an obvious deficiency in total IgG. Normal range is around the 620 range, and she's at 240. IgA is low but not absent, and her IgM is relatively normal. Her IgE was normal as well. But then getting to the second phase, which is the specific antibody testing, she has an absent tetanus response. She has an absent diphtheria response. Her pneumococcal antibody titers were present to only 2 out of 23 serotypes. Now, we don't know when she has ever received a pneumovax before, likely never, because she's too young. So this is, at her age, still considered low, as we would think an adult in this decade would have at least half of the serotypes offering her protection in that panel. And then we noted that her isohemagglutinin panel was quite low. She's a type O blood group, which gives us the advantage of being able to look at both antibodies to A and to B, and both of them are below what we would consider adult normals.
So this is our current differential with Deborah. What do you think about this differential and how we might proceed forward?
So I think it's important for a practitioner to remember that there's other conditions besides immune deficiency that can mimic recurrent infections. For patients that have allergic rhinitis or increased susceptibility to sinusitis, patients with asthma can have increased frequency of pneumonia. Patients who have GERD can present with upper respiratory symptoms. And so it's important to also include some of these non-immunologic issues. Obviously with Deborah, she has problems with symptoms beyond that, including lymphoproliferative disease, and as Chris mentioned, the important past history of ITP.
So here's Deborah's spirometry. You can see on the left is a normal flow volume loop, where the right is Deborah's. It clearly shows obstruction. Any further thoughts on how we should go forward with Deborah, given her physical exam and history?
So this shows a flow volume loop of spirometry, which is obstructed. And somebody could go further and look at diffusion lung capacity. This is the ability of oxygen to move from the lungs to the blood and can be a sensitive marker for lung disease. And also, it's a good test to follow lung disease over time. And this may be a consideration for Deborah.
So now that we're considering a diagnosis of common variable immunodeficiency in Deborah, let me step back a little bit and talk about the diagnostic criteria as put forth by the European Society for Immunodeficiency in 2014. And it's made up of several bullet points, but I want to highlight the first one, which is at least one of the following: increased susceptibility to infection, autoimmune disease, granulomatous disease, unexplained lymphoproliferation, and a positive family history. You only need one of these criteria, together with hypogammaglobulinemia, that is low IgG and usually decreased IgA with or without a low IgM, poor response to antibodies, as we just talked about a few minutes ago, exclusion of other secondary causes of hypogammaglobulinemia, such as loss in the GI tract or renal system, diagnosis after age 4, and obviously to exclude profound T-cell deficiency like we see in severe combined immunodeficiency that usually present very, very early in life. But the important thing about that criteria is that patients initially may not present with increased susceptibility to infection, but they may present with some of the other criteria, including autoimmune disease or other aspects of chronic lung disease.
I think we have, as a community of immunology and treaters, tried to make that point with hematologists, that when you have a patient coming in with a cytopenia, to consider an underlying primary immunodeficiency and not just the cytopenia.
Chris, based on the information we have thus far, what do you think about Deborah's diagnosis?
Totally agree with the CVID diagnosis. She meets criteria for CVID. She obviously has lung disease, not just based on her spirometry, but based on her imaging as well. And so I think at this point we can call this bronchiectasis, and it deserves a little more attention. We should probably consider getting her in for bronchoscopy, something that can help us with cultures, maybe even biopsies. And as a part of the bronchoscopy, we could do lymph node biopsy through her chest to look at the lymphoproliferative issues, or select a peripheral node to do a lymph node biopsy, just to see if there's a granulomatous infiltrative process that we typically see in CVID, or is this another type of process like a lymphoma that should be ruled out. But I definitely agree with the underlying primary immunodeficiency diagnosis of CVID.
So this slide shows that patients may have more than just increased susceptibility to infection. They may have autoimmunity, other types of inflammation, possibly underlying lymphoproliferative disease or even malignancy. Can you comment about the complexity of?
Yeah, these patients need a multidisciplinary team. And just like I mentioned before, we're not doing bronchoscopies, right? We're referring out for pulmonary consult. And I think formal spirometry is important. So you have to have a multidisciplinary team for these patients. It's not appropriate for one specialty to own it all. I think primary care is listed at the top of this list for a very specific reason, as they act as the hub for these patients, collecting the input from all the specialists involved. I think a patient that may start out maybe with a recurrent infection PI presentation will eventually morph into another component, may develop autoimmune disease, may develop bronchiectasis, may go on and require sinus surgery. And so having that multidisciplinary team is a very important connection. And the primary care is that hub, because that's where the communication really needs to come from.
Yeah. Niraj, can you comment on the spectrum of comorbid conditions in common variable immunodeficiency?
CVID is so much more than recurrent infections. It really encompasses a broad range of symptoms and, unfortunately, complications. The myriad of complications that affect CVID patients is very broad, but two of the most common complications include autoimmunity and lymphoproliferative disorders. And I think this gets back to the fact that the important part that Chris brought up is that this is where you need help with a multidisciplinary team, and you can use assistance with multiple subspecialties to really manage a patient efficiently.
And I think the communication between those specialists is really a challenge, but is so necessary, because I, as an immunology provider, may be more tuned into a granulomatous interstitial lung disease versus a pulmonologist who may be more tuned into the infectious complications. And so being able to have a discussion as a multidisciplinary team is so important in the patient's best interest.
Niraj, how helpful do you think genetic testing is? This is an interesting article that shows in a select population that in 40% of patients they could identify a underlying genetic cause for the common variable immunodeficiency.
Right, Mark. I think genetic testing is proving more valuable, and we certainly use it in our practice. This particular paper looked at CVID patients that had particular types of issues. One of that was early onset, low B cells, autoimmunity, and inflammatory complications. So I think when genetic testing is used in a targeted population, the results can be pretty impressive. 40% of patients in this particular study that had targeted testing had an underlying immune deficiency, which is allows again for better diagnosis, better management, and better therapy and targeted therapy. Also, it still shows you that 40% is not a high number, and we still have a long ways to go.
And I would add to that, the anticipation of other complications can be outlined a little bit better when you have a genetic cause. When you know the gene, you may have screened this patient for a genetic PI cause and learned that they are at risk for a cytopenia. That may increase your surveillance. That may change the way you approach the patient.
Well, let's look at the responses to the poll we asked earlier. The question was, which of the following primary immune deficiencies are most common? So let me give our panel the answers. So for severe combined immunodeficiency was 7%. For humoral or antibody immunodeficiency was 56%. For phagocytic abnormalities, 4%, T-cell immune deficiencies, 31%, and complement defects, 2%.
Pretty
Comments?
Well, I think the audience recognizes that humoral deficiencies are pretty common, and I think that that is an important aspect when you're considering a patient for immune deficiency.
Well, let's focus on treatment. So our learning objective number 2 is implement evidence-based treatment strategies to manage PI. Here are some of the management considerations for Deborah, and we're going to focus on antibody replacement therapy for her. Christian, what are the current treatment options that we have available to us?
So starting with the immune globulin replacement discussion, we put this chart in not because we expect anybody to memorize this chart, but it's an illustration of all of the products that are on the market right now. This changes. And we know that as treaters, it changes almost quarterly. New products come on the market, old products go off the market. But this is really just to illustrate that we have an ability to select the route of administration, either IV, sub-Q, or facilitated sub-Q. And then we have a bunch of products to choose from. So if a patient is not responding well to one, we have the option to change to a different product. In selecting IG therapies for the patient, we designed this chart to help us have a discussion on what fits best for the patients, because it's an ever-changing playing field. And this helps illustrate the three main ways: IVIG, sub-QIG, or the facilitated with hyaluronidase. And have that discussion with the patients, which we'll talk about a little bit later, as each one of the therapies has its advantages. And we'll see this chart again.
So we now have another audience response question. With the diagnosis of CVID, you now decide to place Deborah on immunoglobulin therapy. What dose of immunoglobulin replacement would you select? A, 300 milligrams per kilo, B, 400 milligrams per kilo, C, 600 milligrams per kilo, D, 1,000, and E, 1,100. Niraj, can you comment on some of the variables related to the administration of IVIG?
Sure. When a practitioner is administering IVIG to a patient, the dosing is generally about 400 to 600 milligrams per kilogram per month. The infusion interval can be monthly, 3 to 4 weeks on average, and can be adjusted according to patient's symptoms and how they're clinically doing. Infusion rates are generally titrated to patient tolerability, and with monitoring during an IVIG infusion, vital signs are important, and hydration.
Kristen, what about sub-Q immunoglobulin therapy? How would you select a patient? How would you convert them from IV to sub-Q?
So sub-Q IG is super flexible in its dosing. It can be given once a week. It can be given every other week. It can be given once a month with a facilitated method. And some patients even choose to do small doses of it daily or near daily. And so the flexible dosing schedule is something the patients have really appreciated. Customizing the therapy so that the patients get the right volume per site, the right number of needles that they put in for each infusion, all of that is a discussion that is flexible and you're able to have with each patient. And if we do it wisely, then the complication rates are decreased. So if you tailor the volume per site, the length of the needles you use for injection, you can decrease the local reactions that patients experience. And I think above all with sub-QIG, the clinician's responsibility, whether it's the provider prescribing it or the nurse who's educating the patient, managing the expectations of the patient becomes very important. For instance, we know that the longer you are on sub-QIG, the less you have a local reaction. So after the first 60 to 90 days, most patients don't even remember to comment on their local reactions. So if you manage that expectation, it's not a non-issue when we get out 3 months.
So on the next slide, Dr. Banagor proposed a number of years ago this concept of biological trough levels. Niraj, could you explain what he meant by that?
Sure, Mark. Biological levels are a theoretical IgG level that above which keeps your body healthy. And an easy way to think about it is, let's say you and I were both patients who had primary immune deficiency disease with recurrent infections. Now our biological levels are different because they're individual. Your biological level may be 600, so an IgG level above 600 would keep you healthy, but my biological level may be 800 and I need a level above 800 to keep me healthy. Let's say we both went into the physician's office, we had our blood drawn and our serum IgG level were the same, let's say 700. And since your biological level is 600, with an IgG level of 700, you're feeling great because your IgG level is above your biological level. But let's say for me, my biological level is 800 and an IgG level of 700, I would be having frequent recurrent infections. With that in mind, if you take a look at this graph, this is a graph looking at an IgG level over time in a patient. And what this graph illustrates is that concept where when the IgG level is above the biological level, the patient is free of infections. However, when the IgG level goes below the biological level, the patient suffers from respiratory infections, including sinusitis and pneumonias.
I think this is a discussion that's worth having with payers too, because everybody from a payer authorization standpoint thinks there's one normal IgG. And to lump every patient into a normal IgG level really negates the customization of treatment.
Raj, can you comment about what patients can expect with regard to these infusions? What are some of the adverse events? How do you monitor the infusions? What about treating adverse events?
Sure. So with IVIG, the adverse events can be a lot, and they can range from severity of mild, moderate to severe. While there's a lot of reported adverse events, probably the most common adverse event is infusion-related flu-like symptoms. So things like headache and low-grade fever and chills.
Chris, can you comment on how we might optimize or minimize these adverse events?
Absolutely. And the strategy for minimizing adverse events differs between the route of administration. With IVIG, the vast majority of reactions are going to happen during the infusion and are almost always related to the rate of infusion. So it's simple to say that if adverse events develop during infusion, slow the rate. Stop and then restart at the lowest, slowest rate or fastest rate tolerated. Also, having the patients come into the infusion well hydrated makes a huge difference, not just to ease the start of the IV, but also cuts down on those headaches and the flu-like symptoms that come as a result of the actual infusion on the day. Post-infusion reactions can happen 48 to 72 hours after the infusion, and again, that can be body aches, stiff neck, headache. Those are also sort of moderated by improved hydration after the fact. We can also add pre-medications. So if rate changes are not enough to ameliorate the symptoms, adding a pre-medication, Tylenol, something simple as that can help. Benadryl, any long-acting antihistamine even can be helpful. And then Solumedrol or Solucortef added pre-dosing if you're not able to control it in other ways. If we do all of that with IVIG and we still can't get the patient comfortable, they're still having side effects that last beyond the infusion, consider a change in the manufacturer, because each manufacturer uses a different stabilizer or a different viral inactivation step that patient may be having adverse reaction to. So that's kind of the algorithm for IVIG. For sub-Q IG related, we've mentioned some of them. Most of the complaints of sub-Q related side effects are local. They have increased redness, itching, persistent swelling at the site of injection. And just making sure that we have the right equipment for the patient can make a huge difference. A longer needle will help cut back on those symptoms. Accessing the skin with a dry sub-Q needle rather than one that has IG on it will cut back on the local reaction symptoms. Again, managing expectations becomes really important in the sub-Q population, because if they're expecting this to be, rainbows and unicorns off the bat, they may be disappointed with the stinging and the itching they get initially. But to be reassured that within 60 to 90 days, that's going to get better, they can push through. And also, same thing, there is a small percentage of patients who do get headache, who do get flu-like symptoms with sub-Q IG. In those cases, tailoring to them by either cutting their dose in half and putting it twice a week, or changing product for them. Now that we have more options on the market, that becomes a real option for the prescriber.
So let's go back to our second question. Let me give the panel the results. So the question was, with the diagnosis of CVID, you now decide to place Deborah on immunoglobulin therapy. What dose of immunoglobulin replacement would you select? So A, 300 was 7.5%. B, 400 was 60%. C, 600 milligrams per kilo was 32%. D, 1,000 milligrams per kilo was 7%, and E, 1,100 was 2%. Comments?
Well, it wasn't really fair. The question wasn't really fair because the dosing range, like you said, was between 400 and 600. In Deborah's case, I would go on the high side for her dosing. You?
Yeah, I think this illustrates, especially from the audience response, that the individualization of IgG is unique, and you can tailor the IgG dose and the range based on the clinical response. I totally agree with Chris. I would have gone on the higher range given the complications that Deborah had, particularly pulmonary disease.
Right. Actually, there's a very nice paper by Lucas and Helen Chappell from the UK where they did a prospective analysis of their patients with XLA and CVID, where they found that patients with bronchiectasis required a higher dose of immunoglobulin replacement therapy. So let's move on to the third learning objective, which is to educate and inform patients about PI to reduce morbidity and improve the quality of life. Here's our last polling question for our audience. The question is, how often do you engage in patient family when determining the mode of immunoglobulin administration? A, never. B, 1 to 25%. C, 26 to 50% of the time. D, 51 to 75%. Or E, 76 to 100% of the time. You should now go ahead and vote. Christian, can you give us a little bit of background and your thoughts on what we mean by shared decision-making in PI patients?
Absolutely. Shared decision-making is combining patient preference and goals with the key clinical information that the prescriber has. And putting those together supports the patient's informed preferences. So if I give my opinion and I give all the pluses and minuses to the patient, we're going to do a better job of making decisions that meet both of our needs. On this particular patient, I think it's important to talk about lifestyle. Like, where is this patient coming into immunoglobulin replacement therapy? Is she a working woman? Is she a stay-at-home mom? What is right for her today may not be right for her tomorrow. So in shared decision-making in primary immunodeficiency, these conversations have to be ongoing. It needs to be a fluid discussion, because as a new diagnosed primary immunodeficient patient, she may have no information to go on. She may be just overwhelmed with her diagnosis, overwhelmed with her options, and this may be an opportunity for us to choose for her, as long as we're keeping the door open for her to evaluate her treatment on an ongoing basis. And she needs to be included in that every step of the way. The next slide shows a sort of a revisit to what we started with. And this is a chart that I use with my patients to have a discussion on the pros and cons of each of the 3 routes of administration. That each one of them has a downside, each one of them has a positive, and fitting them with her life is going to increase her adherence to our plan of treatment. And then within each one of the choices, she can choose the site of treatment. Does she want to get her infusions at home? Does she want to be in a healthcare facility? Sometimes the healthcare facility is a real source of comfort for patients. Recently had a patient who was on sub-Q IG fall off in her adherence. And when we came back to this chart, she said to me, I don't like doing my shots at home because they make me feel sick. They make me feel like I am ill. And so taking that sort of medicalized treatment out of the home and back into an infusion center made her feel more normal. And so as long as the patient knows that we're going to go back to this chart, we're going to revisit this chart from time to time. Is your therapy still right for you? Those are sort of the pillars of shared decision making in patients with any chronic disease, but especially primary immunodeficiency disease. There was a time when we've all practiced in that time frame, we didn't have any other options to offer them. It was, here's your disease, here's your therapy. You can either get it in the hospital or you can get it at home. So we are lucky to be able to have a discussion that is this broad with the patients. We just can't forget to keep going back to this discussion.
And Raj, what about your experience?
Yeah, I think the shared decision making is so important, and it certainly can impact adherence and quality of life. When we have a discussion with the patient, it's in a very similar fashion, and it's really a group decision between what works for the patient, and following and monitoring that, just like Chris said, is an ongoing basis, because things change, factors change in the patient's life, and they may have differences that didn't work at one point but then work later on.
Well, I can share some of my experiences. When I was in private practice in Sarasota, I was taking care of an elderly population of patients with common variable immunodeficiency. And after this dialogue that we were all talking about, shared decision making, they wanted to go to the hospital, to the local hospital, because they were retired, so time wasn't a factor, and they had some socialization in the infusion center with other patients and the nurses. So for them, that fit in with their lifestyle.
And I think the elderly population especially appreciates the expertise of people taking care of them, that they don't necessarily trust themselves as much as they trust their doctors and their nurses who are taking care of them on site. So there is some confidence in their therapy that way.
Yeah, Mark, let me just bring it back also to the other end of the extreme, the pediatric population. You know, it's a shared discussion with the parent, and I think the parent oftentimes is very reluctant or very hesitant to really engage in the administration of gamma globulin. And so it's important to take feedback and important to reassure and give as much information about the training process and what life will look like for the child for the parent to make the best medical informed decision.
Well, to emphasize that point, let's go to the next slide. And this is an interesting study. There's lots of studies on quality of life and its relationship to mode of therapy and timing of therapy, et cetera, et cetera. But I thought this was an interesting quality of life study because there's a take-home message here. Chris, you want to?
In health-related quality of life in the primary immunodeficient population, there was no difference in the route of administration as long as the patient had been involved in the decision-making to get there. So to pare it down, whether they received IVIG or sub-Q IG, their quality of life was perceived to be the same if they had received adequate education.
Niraj, any further thoughts on?
No, I just echo Chris's sentiments. Sure.
Yeah, I mean, I find the same thing. I discuss with patients the options as we just discussed with your nice table, but I let them know that it's not fixed in stone. It could be changed, and we can explore other methodology. I know this is particularly important in the pediatric age group because initially we may start a patient on IVIG to get their immunoglobulin levels up and running because they may have profound hypogammaglobulinemia, like a patient with X-linked agammaglobulinemia. But during that process of the IVIG, we have a continued discussion about other routes of therapy, like switching to sub-Q.
Right, especially when you're launching these kids to college, right? So you send an
another
XLA child who's been getting IVIG for all of their life, and all of a sudden they're 18 and off they go to college. You have to have a discussion on what's going to fit best with them with their launch. I start having these conversations with kids at about 12 years of age. Like, you're not going to be in your mama's house forever, so what comes next? Start thinking about it.
No, I think that's an important point, is to empower the teenager to take control. So it's not only communicating with the parents, but at a certain age where the teenager starts to understand a little bit more about their disease and management, is to have that conversation with them as well. I think that's critically important. Well, I want to thank you, Niraj and Kristen, for this great discussion. Let me now summarize the key takeaway or our SMART goals for today's presentation. First, conduct a careful history, physical exam. Family history is extremely important. That plays into it is also very important. Utilizing screening evaluation as we discuss, not only the quantitative serum immunoglobulins, but also the qualitative tests of can patients make a antibody response. Next, to individualize immunoglobulin dosing and the communication with the patient about the mode of delivery to prevent infection, and which translates into improving adherence and quality of life. Finally, discuss therapeutic options and engage the patients on a regular basis. This is an ongoing, it's not once and that's it. I want to remind the audience that I partnered with CME Outfitters to offer 3 very useful patient education tools. a whiteboard animation describing primary immune deficiency and what to expect during the diagnosis and treatment phases, a frequently asked question checklist about PI, and a video providing insights into shared decision-making strategies for patients to improve their communications with their clinicians. I encourage you to visit www.CMEOutfitters.com for a comprehensive list of clinical resources and additional educational activities for both providers and patients. Well, welcome back, everyone. We have received some questions, so we're going to jump right in. I'm going to describe the question and let our panel discuss them. Can you provide more specifics on how you determine treatment choice to adult patients? What route do you start with, and what may push you to change routes?
I'll start with that. Sometimes the degree of hypogammaglobulinemia will help me determine what rate to start with. If I have a patient who's starting out, like just last week, diagnosed somebody with an IgG of 36, number 36. And so that's a patient where I would start with IVIG just to get the rate, just to get the levels up at a quicker rate. Then you could transition the patient from IVIG to sub-Q IG to maintain those levels. So I would rather have the patient get their levels up quickly, and then when we start the sub-Q IG as close as we can after an IVIG infusion so that we keep those levels up and then can maintain a biologic titer higher than if you were starting sub-Q IG from the basement.
And I think in terms of switching immunoglobulin, again, Chris did an excellent job talking about shared decision making. And so it's really important to have the patient understand what are the different factors of sub-Q and IVIG and what may fit into their lifestyle. And as was mentioned before, starting out with one conventional route doesn't obligate you to continue that. And as Chris mentioned, in some patients, a switch from IVIG to sub-Q based on patient preference, ability to self-infuse may be more important.
Yeah, and I think we touched on this previously about lifestyle. So, what might be good for one patient may not be appropriate for another. So, for example, if you have a traveling salesperson who makes it very difficult to schedule IVIG infusions, but we know that sub-Q is much more flexible, more portable, and they can do it on the road. We mentioned the patient going off to college, and the soccer moms. In my experience with my patients, the mothers with young children actually, love the subcutaneous route because it was so flexible. They could do it while their child is doing their homework, etc., or whatever, and they don't have to bother with, with scheduling.
I use that chart that we showed. I give that to my patients so that we can have that discussion and they can take that discussion home with them, because it has the hows, it has the whys, it has this, the pluses and minuses of each therapy. And so sometimes we can't, sitting face to face in my visit, we can't decide. We need a break, go home, read your information, and then let's come back together in 2 weeks and let's talk about where we go next, what our options are, and what did you decide on.
Okay, we have a lot of questions, so let me go on. In a patient with PI, is there data regarding long-term pulmonary outcomes?
So I think you had mentioned a study, Mark, looking at patients with CVID and bronchial pathology. And that study particularly stressed the number of pulmonary complications. There were over 200 patients in that study. They had received a CT scan of the chest. And I think it highlights the importance of screening your patients. When you have pulmonary complications like a bronchiectasis or mucus plugging, that can impact your patient's symptomatology and ultimately how they respond to therapy and their quality of life. So it's important to recognize those complications. Some of them, like bronchiectasis, unfortunately may not be reversible, but to identify them early and make sure that you have the assistance with a multidisciplinary approach, get your pulmonologists involved, and really use that to help prevent any long-term effects from concurrent pulmonary complications.
One of the things that I have often come to meetings and asked the questions is standard screening for primary immunodeficient patients for lung disease. So everybody gets a baseline chest CT out of my clinic, but then what is routine surveillance? Outside of doing pulmonary function testing, do you screen your patients with CT?
Yeah, I think that's a great question. I think it's probably variable.
Mm-hmm.
Patients who are clinically doing well mm-hmm. and whose symptoms are well controlled, you may not be as concerned mm-hmm. for those patients as patients who, despite getting what seems like to be appropriate treatment, are getting repetitive pneumonias, may have further end organ damage. I think I would be more aggressive in defining and maybe repeating
sure.
Certain tests like a chest CT.
Mm-hmm.
Yeah, I mean, that's a frequent question. Mm-hmm. In my own practice, I think any patient that has a history of pneumonia deserves a chest CT, mm-hmm. or any patient that has underlying chronic lung disease, as Deborah came in with asthma. And so, not all chronic lung disease is asthma. All that wheezes is not asthma,
mm-hmm.
right?
Right.
So it's certainly worthwhile doing a high-resolution chest CT. Now, how often can you get it? You have to be careful. Mm-hmm. It does offer radiation to the lung. We know patients are susceptible to lymphoma and as well as some other cancers. So you can't do it often. Right. So that's why lung function tests, mm-hmm. spirometry, as well as diffusion capacity is an important way to follow these patients. Okay, what are the best genetic tests for determining PI? Are there new recommendations from the Academy?
So the genetic testing is rapidly evolving, and there are multiple platforms for genetic testing, and it really, while there are a number of genetic tests available out there, the targeted panels seem to be the most popular and often the most effective. When you have a patient who has who is in need of genetic testing, the next generation or targeted sequencing panels can really allow you to focus in on select genes, typically 200 to 300 with most currently available gene panels. And they are they have the advantages that genetic testing didn't have 5 to 10 years ago. They have a rapid turnaround time, typically 4 to 6 weeks to get results available. And the cost for genetic testing compared to 5 to 10 years ago has really come down. There was a summary statement regarding a genetic testing put out by the Academy in 2019 that summarizes genetic testing indications as well as the different types of genetic testing available.
I also think that with commercially available targeted gene sequencing, those companies are keeping databases of the variants of undetermined significance. So I think they are helping to contribute to the future genetic anomalies that are associated with the phenotypes that we see.
Yeah, that's a great point. And Chris, just to piggyback off of that, the variants of uncertain significance are typically mutations in genes associated with PI that there has not been any literature-guided known significance or pathogenic significance. So, just like things are, there's pluses and minuses, there has to be careful interpretation with genetic testing, and sometimes variants of uncertain significance can be difficult to determine about the direct impact. And currently there are ongoing research groups mm-hmm. who have collected these variants of uncertain significance and are looking into what is the clinical implication for PI.
And a topic that, off record, that Chris and I had a conversation with, there are other immune deficiencies. We talk mainly about common variable immunodeficiency, but there are other immune deficiencies that particularly present in adults, but also in children, that are gain of function mutations. And the important in identifying them is that we now have some alternative therapy,
Right.
or adjunct therapy, I should say adjunct therapy, to immunoglobulin replacement to counteract the gain of function of these abnormal genes, hyper IgE, STAT1, STAT3 defects, and PI3 kinase deficiency, etc. And the list is growing. So we're in a new world now of precision medicine with regard to primary immune deficiencies and
autoinflammatory stuff. Those diagnoses made genetically really help you pare down the treatment choices for the patient. I mean, there are immune suppressants that are really well studied in some of those genetic findings, especially the gain of function.
Yeah.
And I totally echo your point about targeted therapy. Some of those gain of function defects like STAT1 gain of function has really allowed medications to come on board, often that actually have no immunosuppressive effect, but allow to control the adverse problems associated with the gene. And as a result, we know in some of these gain of function tests, one of the things that's a long-term benefit is the prevention of autoimmunity, which is one of the most common complications of primary immune deficiency disease. So I think it's an exciting time for genetic testing. I think there's definitely more to come as the audience has seen with increasing number of genetic known diagnoses.
Great. Another question is, how do we treat Deborah and why? So I can tell you my thoughts. She had profound hypogammaglobulinemia and IgG, I think of, if I remember, 240 milligrams per deciliter. So we want to get her up and running, so we'd start her on intravenous immune globulin. But after conversations, shared decision making, we switched her to subcutaneous immunoglobulin, and she has done very well.
I then referred her to pulmonology, where she underwent bronchoscopy, and they did not culture any pathogens from her lungs. They did, however, do fine needle aspiration of one of the nodules and discovered non-caseating granulomas and have lymphocytic infiltrates into those nodules.
I think when you start to talk about multiple subspecialists, here's again the team approach where you have a lot of multidisciplinary teams impacting the patient. You have an immunologist, you have a pulmonologist. You know, Deborah also had a lymphoproliferative disease, a large liver, so it wouldn't surprise me, you know, if at some point she had a gastroenterologist involved. But it's so important for all of these specialties to communicate with each other. And this just, I think, defines how complex some of these patients are, and they need a team approach.
So how would you select an IVIG product? And any comments about the stabilizers?
Well,
And what role they may play in adverse events?
so my conversation about that now is much different than it probably would have even been a year ago, because I think a lot of payers now are making formulary choices for immunoglobulin products. And so first and foremost, the authorization of this expensive therapy has to happen. And so I usually, when I have a Deborah come through my office, we'll start the prior authorization for IVIG before we've even settled on that, because that could be 2 to 4 weeks. And I want to get her started. It's middle of the winter. So we want to make sure that we can expedite her therapy. How do we choose a product? Pretty much across the board, the commercially available products now have equal safety and efficacy. And so sometimes it's best guess. Getting started if the insurance company isn't dictating anything. So when we're choosing an IVIG product, their stabilizers of glycine or proline are pretty comparable in safety and efficacy, and side effect profiles are pretty comparable. So it might just be a guess when you choose a product.
Yeah, stabilizers aren't as important to me as the product efficacy, and just as Chris mentioned, the products all work. They're all efficacious. And if it's driven by insurance or it's natural selection in your pick, then really I think for me it's how the patient responds. I also believe it's important to set expectations, and I think Chris does it very well, to know that once somebody is is determined to have an immune deficiency and you start them on immunoglobulin therapy, it can be unfortunately weeks before you can get started. And that just simply has to do with having insurance to be able to approve immunoglobulin therapy. And so from a patient perspective, a lot of times, they want to start right away, but it's important to set those expectations up front.
Okay. Is DVT a side effect of IVIG?
So there was a slide of IVIG adverse events, and the thrombosis is a warning for IVIG. And I would say to the practitioner, if a patient has increased risk for thrombosis, is elderly, has a central line like a port, then those would be concurrent risk factors from thrombosis. And in that particular case, then you can do some things with the IVIG infusion to help reduce that risk, like slowing down the infusion rate, giving a dose that's closer to the lower end of the infusion range of, let's say, 400 to 600 milligrams per kilogram.
And while IVIG is the one that's probably most commonly associated with thromboembolic events, it's a warning for all IG products, whether it's sub-Q or IV. They all carry the thromboembolic risk. And so I think from a clinician standpoint, we do all we can to moderate that risk, choosing the right patient, choosing the right route, choosing the right rate. But as other clinicians, your level of suspicion is higher. You have a patient coming in with a sore calf and a little bit of swelling, you're going to be more suspicious of a DVT than in a regular healthy patient, not on immunoglobulin.
So just an additional comment about that. A number of years ago, maybe 5 or 6 years ago, one of the products was taken off the market because of these thromboembolic events, and we identified that there was a procoagulant activity in the gamma globulins, some more than others. So now all the manufacturers are very cognizant of this procoagulant activity, and they have modified their manufacturing to minimize, and they actually test now for this procoagulant activity to make sure that the products we have today minimize that threat.
And I think across the board, all of the products are exceedingly safe. I mean, even when you talk about the broader adverse reactions, we almost never see acute renal injury without a sucrose product on the market. So sucrose was responsible for 90% of renal injury associated with IVIG, and that product hopefully isn't in wide use anymore. So I think exceptionally, our manufacturers have done a great job in paring down the risk profile.
Another question, what is the value of high-resolution chest CT in interstitial lung disease?
So, for high-res CT, interstitial lung disease is something that can be identified. There's a lot of different etiologies of interstitial lung disease, but I do think it's important. High-res CT can also give you so many other findings, and as was mentioned before, bronchiectasis, mucus plugging. Bronchoscopy can also help with interstitial lung disease if you're worried about viral etiologies of interstitial lung disease, lung biopsies. Those are other methods to help with the further characterization of interstitial lung disease.
I also know that in Deborah's case, the degree of bronchiectasis that you could see on her high-resolution chest CT, I would have ordered vest therapy for Deborah to help with some small airway clearance, working on trying to use mucolytics to break up her mucus plugging and the thickening of her airways. So I think you wouldn't have seen that, like you demonstrated on the chest x-ray. You wouldn't have seen any of that until you put her in for a high-resolution chest CT.
Yeah, and of course the high-resolution chest CT is not only important for interstitial lung disease, but for the granuloma.
Yep.
Like Deborah had some suggestion of granulomatous disease, which we call granulomatous interstitial lymphocytic chronic chest lung disease. So, and that may take us in a different direction as far as therapy or management. Can you comment on dosing of immunoglobulin in pediatrics?
So IVIG and subcutaneous IG for ages 2 and above, the dosing range is similar than to adults. So for IVIG, 400 to 600 milligrams per kilogram. For subcutaneous IG, 100 to 150 milligrams per kilogram per week. For the reasons that you mentioned, Mark, about patients who, let's say, are pediatric who have X-linked gamma globulinemia, really you may want to go to the higher dosing range if they have profound hypogammaglobulinemia. And I think this case in an adult patient demonstrates that quite nicely for somebody like Deborah who had pan-hypogammaglobulinemia. But really for pediatric considerations, there's the consideration for not only just immunoglobulin dosing, but also with route of administration in terms of IV access versus subcutaneous, and things like whether the child prefers to give the dose in an infusion center or likes the comfort of their own home, systemic side effects. There's also the issue with multiple needles with pediatrics that can be more prevalent in subcutaneous IG compared to IVIG.
I agree with all of that. I think the per kilo dosing translates across the lifespan. Then also, using clinical responses to guide your dosing as well, because kids will outgrow their dose. Do you do it to the T? Like if a child gains 10 pounds, do you go up by 1 gram? I mean, like how you assess that isn't based on a straight curve. You got to look at, pattern of infection. You got to look at what are their troughs. Where are they at trough? So all of that has to play a role in your dosing, but I think starting at the per kilo dosing across the lifespan is appropriate.
Okay. I just want to add a couple of points. One, in the pediatric age group, sometimes kids are finicky about needle sticks, and so we use Emla cream. It's a topical anesthetic, very successfully, and they kind of get over that fear, and we find that after a while they don't even need the Emla cream anymore. That's one issue. The other issue is about updosing. Never break a vial in half. Always give the whole vial. Don't throw it away.
Yeah,
Right?
absolutely. Absolutely. Yeah, we don't waste. And that kind of goes across the board, whether it's sub-Q dosing or IV dosing. If you dose per kilo, and like I said, you don't dose it by the calculator, you dose it clinically. If a patient's dose comes out to 36 grams, you have to decide, am I going to give 35 or am I going to give 40? Some come in 2.5 vials, so you could do 37.5 too. But yeah, I totally agree with that. And also, dosing isn't linear, right? Like in a kid as they grow, I have almost never seen linear increases in dosing. I'll have a kid that's doing great, and then all of a sudden, they're not, and it has nothing to do with their weight gain. It may have to do with metabolism changes, hormonal changes, those kinds of things. So being tuned in, and we were talking about this earlier. I see any patient who's on immunoglobulin, I see them about every 6 months to have these discussions.
Okay. I work in the emergency department. What recommendations would you have for providing care for these patients when they present to the emergency room with bronchitis or other lung disease? Good question.
Yeah, that's a great question. I think understanding what the underlying immunologic defect is first, and whether it's an antibody deficiency, whether it's a complement deficiency, because I think those patients you're going to approach those patients somewhat differently. So as we talked about with Deborah and a patient who has CVID, knowing that this is a primary antibody deficiency, things to evaluate would be more probably along the line of pathogens associated with clinical symptoms associated with antibody deficiency. So things like sinus issues, pneumococcus, H-flu, things like bronchitis with the similar sort of patterns. And that can help facilitate diagnosis. Is this somebody you get a chest x-ray on versus somebody who has perhaps a complement deficiency that may present with a more severe type of infection. Let's say they may have bacteremia or meningitis, and in those cases, the evaluation should occur promptly. Maybe antibiotics should be addressed up front.
What about isolating them from other patients in the emergency room who are sitting there coughing and wheezing and
Absolutely, yes. I think you don't want to add insult to injury, and so isolating them as soon as they come in is super important.
I'd like to interject too that these are not your community-acquired pneumonias. When a patient with immune deficiency comes in and you auscultate something in their lungs, I guarantee you that their immunology provider would appreciate a chest X-ray to document a pneumonia versus just a bronchial infection. And that's a big discrimination for me, because pneumonia in a patient who's on treatment and who's properly dosed, that represents a failure at that present dose and does need to be addressed with either dose increase or interval decrease. So when you're a urgent care or emergency room provider and you're making a guess at something that you could further classify, I would ask you to classify that for me.
I also think as an emergency room provider that when you encounter a patient who has immune deficiency and you make a clinical assessment and a clinical plan, is to make sure that the persons who are involved in that patient's care are updated. I think making sure there's a plan of care for follow-up, and most emergency room providers are very good at that, but also making sure that either the patient or the emergency room provider sends notes to the immunologist, or if it's a lung disease, immunologist, maybe pulmonary, because, again, the multidisciplinary approach is very important and very effective, and if a pulmonary provider, immunologist, knows that a patient is not doing well, they may be much more apt to see them sooner, adjust their immunoglobulin therapy, and may have long-stream effects.
Right. How would you transition someone on IVIG to sub-Q?
We talked about this previously. So the package insert says that it's not a gram per gram conversion rate. So if a patient's receiving 30 grams of immunoglobulin per month, the conversion rate to sub-Q is 1.36 in most package inserts for the conversion from IV to sub-Q. We typically like to make the conversion when the IV dose has just been given. So within the first week to 5 days after immunoglobulin IV is given, we'd like to start the sub-Q. So we're getting them at their peak and then maintaining them at a steady state with the sub-Q IG. I don't know that all immunology providers use that conversion rate of 1.36. I know that that's variable. And important to note, again, the patient's clinical responses.
So here's a question. They asked me what percentage of my patients are on IV versus sub-Q. And I would have to say most of my patients are on sub-Q. It's just much more flexible, tolerated very well. We have multiple choices on sub-Q products now. As I said, the ones that are mainly on IV, IVIG are the older patient who's retired, who doesn't have time constraints, that can go to the medical center or infusion center, or they can do it at home as well.
I'm about 70-30. 70% of my patients are on sub-Q. We've done this periodically. We've taken a sample to see where we're at. But that feels right, 70%.
And I see a lot of pediatric patients in my practice, more so than adults. And surprisingly, 80 to 85% of those pediatric patients are on subcutaneous IG, and they do very well. So I think whether you're pediatric or adult, probably the move is closer towards the subcutaneous IG. Just as you mentioned, Mark, it's a lot lower systemic side effects, the convenience of doing it in your own home.
Yeah. Again, it comes back to lifestyle of the patient, having a communication with appropriate discussions. Let's see.
It's also not to say that I don't have some sub-Q patients that choose to go back to IV. Right? So I describe this as a needle fatigue, that some of my patients just get fatigued from poking themselves and they want a break. And so they do appreciate being able to switch back at some points from the sub-Q route to the IV route. I have one particular gentleman who does IVIG 8 months out of the year, and 4 months out of the year he's a snowbird and he takes his sub-Q on the road with him. So, but when he comes back, he likes to go to IV.
Okay, here's a question about immunizations. During your workup, once an antibody to a vaccine level is reached and and is low, do you immunize them and repeat the level again in 4 to 6 weeks, especially for pneumovax?
I think that's a hard one to answer as a generality because it depends on the patient. If I have a patient like Deborah, who has an IgG level in the 200 to 300 range, and I do vaccinate her, and I do get an initial response, I may recheck those same titers 6 months later because likely she's going to lose that protection. So she may have a good initial response, but then lose it long term. And at that point, then it would be easy for me to say, yeah, she's going on immunoglobulin, that plus her infectious history, if I hadn't already started it. In Deborah's case, whether or not she responded to vaccines, she was going to end up on immunoglobulin based on her profound hypogam and her qualifications for CVID based on ECID criteria. So you wouldn't have revaccinated her again.
Okay. Is there a useful quality of life screening tool to use in these patients?
So there was a recently published paper showing that the health quality of life can be accurately assessed in patients with primary immunodeficiency disease. I think, Mark, you were...
That was your tool, right?
Right. So there's actually 2 validated health-related quality of life survey tools for patients with antibody immune deficiency, adults. We don't have one in pediatrics yet. One is one that I was intimately involved in called the PADQUAL-16. This is a quality of life survey tool that has 16 questions, very easy. It's only 16 questions. It also addresses wear-off, and I'll come back to you and explain a little bit. You can explain a little bit about that. The other was produced by by the Italian group, and they call that the QOL CVID. And that has many more questions, a little bit more complex than the PADQUAL-16. So since I mentioned it, because this QOL tool does have a couple questions about wear-off, maybe you can explain that.
And I think quality of life is impacted by this thing that we as a community call wear-off, and it's a sensation that patients typically on IVIG feel as they come off of their peak of dosing. So patients may be on a 28-day infusion cycle. They get their dose. Many patients will say that they feel energized after their dose. Then over the course of the next 28 days, as levels fall off, and hopefully never below their trough, never below normal, they have a sensation of a loss of vitality. And so they feel more fatigued. They feel like they may be more likely to develop congestion or cough, even though not true infection. But that wear-off is really hard to define. It's very subjective to these patients. Now, on sub-QIG, I don't hear about it. And so that's often a sort of a launch pad to discussion for patients who have wear-off. Oftentimes they go from a 4-week infusion schedule to a 3-week infusion schedule to help, but that often doesn't help. Right. They still feel that fall off from the peak at the 21-day mark. Those are the patients that I get to start that conversation that you wouldn't have this if you were on subcutaneous administration because your levels are much more stable and you're not getting that peak. And I think that is probably one of the main factors my patients on IVIG transition to sub-Q.
Okay, so here's a very controversial topic, and we're starting to get pushback from the assurers. Obese patients. How do you dose obese patients?
You're both looking at me.
Well, your group was involved in a study.
Right. I mean, there's lean body mass dosing. So you can take a patient's ideal weight or lean, what you would hypothesize as lean body mass, and do your dosing. But that's just a starting point because really you are going to be dosing to response. And that's where the dosing becomes more of a gestalt, more of a feeling, because the patient, pattern of infection has to be evaluated. The IgG troughs have to be evaluated. And again, in the quality of life discussion, how does the patient feel? Like, have they had an improvement in their quality of life? And that's then where the dosing gets tweaked. And I think that you're right in insurance companies pushing back as dosing escalation happens in these patients. Because your blood volume may change based on your body mass, but may not change in proportion to your body mass. So dosing becomes more of a feeling in the obese patient. But again, your starting point is just that. It's just a starting point. Your monitoring of dosing is what's important.
Yeah, this goes back to that biological level.
Yeah.
Insurance companies want to pay a third-party payer for a particular IgG level. But that IgG level in a patient may not be effective. It may not keep them from getting infections. It may not be at their biological level. And so it's very important to once you start, just like Chris said, to monitor. And when you have patients that have frequent illnesses and you need to updose, obviously it's important to document and provide evidence that the patient is not well controlled.
So just a little bit further comment about this topic. If I get a lot of pushback from the insurance company, I've been trying to convince them to use the adjusted body weight.
Okay.
So for example, in an obese patient, and I'm not going to go through the calculations, but let's just say their lean body weight would give them about 28 grams per month. But their actual body weight, the calculation is 60 grams per month. But the adjusted body weight is 47 grams per month, plus or minus. So I try to convince them that that's a starting point instead of using the ideal body weight.
Yeah.
And see where we go from there. Using, again, the concept is how to optimize immunoglobulin replacement
Response,
therapy. Yeah. I'm a primary care physician. What is the best way to refer patients since it often takes so long to get an appointment with an immunologist? What tests should I do to start out with?
Well, I think that from a primary care standpoint, doing the first and second stage of treatment or of diagnosis is appropriate. So looking at quantitative antibody, looking at blood counts, looking at a comprehensive metabolic panel to make sure that protein levels and albumin levels are normal, and even going as far as to look at some initial titers. You don't have to proceed with the vaccine challenges, but looking at diphtheria, tetanus, pneumococcal titers are all appropriate out of primary care, and especially primary care pediatrics.
Yeah, I agree. It's, the first tier and second tier testing is a great place to start. And when there are abnormalities, of course, having an immunologist to interpret is very helpful.
So just as a follow-up, it says, panel, please talk about the delay in diagnosis and what we can do about it.
Boy, that's a great question. And there's not an easy answer. The delay in diagnosis occurs and is likely multifactorial. I think one of the things that we've learned over the course of decades is to have a high index of suspicion. And when you are not thinking about primary immune deficiency disease as a potential cause for patient symptoms, I think that's one of the biggest risk factors for the patient then moving on and on to, let's say, multiple providers. A patient may start out with a primary care provider with the best intent, go on to see an ENT because of frequent sinusitis, and then an allergist for allergy testing, coming back to the primary care physician, all while primary immune deficiency disease hasn't been entertained. And so I think one of the things we can do to improve that diagnostic delay is really educate, and the reason for this program, and get the word out that here are the signs and symptoms, here is what we can do as primary care providers or subspecialists to identify these patients and then get them to the right person.
And I think it's two-pronged. I think educating the providers and also educating the population, the public. And I think Jeffrey Modell has, with their 10 warning signs of primary immunodeficiency, has done a little bit to create the ask in the patient, like, do you think this could be my immune system? The initial screening is relatively inexpensive for this disease, so we don't have to expect the primary care or even the hospitalist who's seeing that patient for his second pneumonia this year. We don't not asking them to spend a lot of money in diagnostics, but getting the first and second pass done, it could make you a hero from a diagnostic standpoint.
Okay, we only have about a minute and a half to go. And Chris, I'm going to ask you this because you did some studies in your office. Is manual push, daily injections of manual push, or maybe twice a week, 3 times a week? How do you view that? Is that an option, and what do patients?
So condensing the answer into a small minute time frame, some patients were looking for easier ways than monkeying with the supplies and pumps that are necessary for sub-Q infusion once a week or every other week. So we challenged the patients to draw their immunoglobulin up in a syringe, attach a butterfly needle, and give the shot. A patient came to us with this request after having completed initial sub-Q IG studies back in 2003 and said, I don't want to carry around a CAD pump for 80 hours to get my my volume. Why can't I just do a poke and a push? And they can, and they do. And we've done some studies that show that when they are able to give a small dose every day, every 5 days, their levels are well maintained.
Great, thank you. Well, I want to thank our faculty, Neeraj Patel and Kristen Applin. Thank you very much for joining me on the stage to discuss this important topic.
It was a pleasure.
Yeah, thank you.